The first skill in airway management is opening the airway. When a patient is conscious and speaking, there is no need to manage the airway. However, when you are presented with an unresponsive patient, you must assess and, if necessary, manage the airway. In other words, if a patient presents as alert or responsive to verbal stimuli and is able to speak, there is no need to open the airway. It is already open. If the patient is responsive only to pain or is unresponsive to pain or has snoring respirations, then the rescuer should assess the patency of the airway and open it as necessary. The most common cause of airway obstruction in the unconscious patient is the tongue. Airway maneuvers help lift the tongue from the airway opening. There is more than one way to manually open a patient's airway, and some methods provide better airway opening than others. However, certain airway opening techniques involve significant movement of the head and neck, which may cause further injury in trauma patients. Therefore, before opening the airway, you must first decide whether a cervical spine injury is likely. A C-spine injury should be suspected in any patient whose collapse was unwitnessed or who has significant mechanism of injury, such as fall from great height, motor vehicle crash, or a blow to the head or neck. For the purpose of determining the correct airway opening procedure, we call these patients trauma patients, meaning patients with suspected neck trauma. Naturally, there are many types of traumatic injuries that do not involve potential neck injury. While these patients are technically trauma patients, they do not require C-spine precautions. If no injury to the C-spine is suspected, use the head tilt chin lift method. Use the modified jaw thrust when C-spine injury is possible. Airway opening is often combined with other procedures, such as artificial ventilation. Finally, since this is an airway procedure, you should be exercising precautions by wearing gloves, and you should also consider goggles and a face mask. Airway opening, non-trauma. Let's see how to open the airway of a medical or non-trauma patient using the head tilt chin lift procedure. This technique opens the airway by tilting the head back while simultaneously lifting the chin up, which brings the tongue forward, opening the air passageway. The head tilt chin lift method is better than the modified jaw thrust at opening the airway, especially when the head is lifted up into the sniffing position, but can cause further injury if the cervical spine is damaged. To perform the head tilt chin lift, place the victim in a supine position. If the patient is in a seated or slumped position, move him or her to the ground if possible. Position yourself to the side of the patient and place one hand across the forehead of the victim and tilt the head back. Use the fingers of the other hand to lift the chin. This pulls the tongue away from the opening of the larynx. Be careful not to press your fingers into the area under the mandible, or you can occlude the airway. In order for air to enter the lungs, it must pass through the oral cavity, pharyngeal space, and into the larynx. Think of these lines of air travel as axes. When the axes are aligned, airflow into the lungs is more direct and thus easier. The head tilt chin lift procedure aligns the oral axis and the pharyngeal axis, but not the laryngeal axis. When the head of the adult patient is lifted a couple inches, the pharyngeal and laryngeal axes are aligned. To align all three, elevate the patient's head on a folded towel. Then perform the head tilt chin lift. This is called the sniffing position and provides the most open airway. To open the airway for a child, tilt the head back slightly. Do not tilt too far back. Hyperextension of the neck during this procedure can occlude the airway since the airway is more flexible at young ages. Infants have a larger occiput and underdeveloped shoulders. This causes the head to flex forward when supine. Therefore, to open the airway of an infant, place a rolled towel under the shoulders to balance the larger head. Both extension and flexion occlude the airway of an infant. Think of the infant's airway like a straw from a fast food restaurant. If you bend it in either direction, you will kink it. Keep the infant's head in a neutral position to maintain an open airway. Airway opening, trauma. The jaw thrust technique is used to open the airway of an unresponsive patient with known or suspected trauma. Any patient who presents with an altered level of consciousness or is found unresponsive on the ground without explanation is presumed to have a possible spinal injury and must have their spine protected. While opening the airway is essential, it is also important to protect the spine. The modified jaw thrust maneuver allows the airway to be opened with little to no movement of the spine. This is accomplished by lifting the jaw, which brings the tongue forward off the posterior hypopharynx without manipulating the spine. The modified jaw thrust is best performed when you are positioned behind the patient's head. The best way to perform this skill is to stabilize the patient's head by placing the fleshy part of your palms on the patient's cheeks alongside the nose. Aim your fingers toward the floor, not towards the patient's feet. Use the fingers to lift the jaw up. This sometimes closes the patient's mouth. If this happens, use your thumbs to open it. The modified jaw thrust can be tiring for the hands. If you find yourself unable to maintain adequate jaw thrust, switch off with another rescuer. If your victim is trapped in a sitting position, you will have to modify your positioning and your technique to the situation. The jaw thrust maneuver is difficult to perform, and sometimes patient anatomy makes it difficult to obtain a patent airway with this technique. If you believe that the jaw thrust maneuver is not opening the airway adequately, you should switch to the head tilt chin lift technique. Your trauma patient may or may not have a cervical spine injury, and even if your patient does have damage to the cervical vertebrae, manipulation of the head into the head tilt chin lift or sniffing position may or may not cause damage to the spinal cord. But if you cannot maintain an open airway, your patient may not survive the incident. Suction. If a patient is unable to manage blood and secretions in the airway, it may become necessary to perform oral suctioning. While oral suctioning is usually a benign procedure, it can cause harm to the very ill patient if performed incorrectly. The vacuum of a suction unit removes not only liquid and debris, but also oxygen. If prolonged suctioning is performed on a hypoxic patient, it is possible to cause cardiac arrest. There are 3 general principles for suctioning. Suction should only be applied as the catheter is withdrawn out of the mouth. The catheter should be swept side to side as it is withdrawn, and suction should not last any longer than 15 seconds per attempt. Ideally, a patient that is to be suctioned should receive oxygen for at least 1 minute prior to being suctioned. Patients who need more than one suctioning attempt should receive a minute of oxygen between attempts. A good idea is to place the patient on a nasal cannula before the procedure. However, it is still necessary to wait 1 minute between attempts. Of course, if the patient's airway is obstructed with fluid, debris, or vomitus, the airway must be cleared at all costs. An alternative to counting to 15 seconds is to hold your breath. When the person suctioning needs to take a breath, so does the patient. Pause suctioning and allow the patient a minute of oxygen. As with all airway procedures, BSI precautions should be taken. Regardless of whether the suction device is mounted or portable, you will need a suction hose or tubing and a suction catheter. There are 2 types of suction catheters, the rigid and the soft. The rigid catheter, also known as the tonsil tip or Yankauer, is the most commonly used catheter for oral suction. Its angled shape allows the user to easily reach all areas of the oropharynx. It is possible, however, to stimulate the gag reflex with the catheter, so it is necessary to measure for depth of insertion before suctioning. To prevent accidentally stimulating the gag reflex and possible vomiting and aspiration, measure the catheter and note how far it can be inserted. Do this by measuring from the corner of the patient's mouth to the tip of the earlobe. This is approximately the distance from the mouth to the top of the larynx. If the patient does not have a neck injury, it is best to turn the head to the side during suctioning. If repeated suctioning is necessary, it is helpful to put a piece of medical tape at the measured point so that repeated measuring isn't needed. There are two models of rigid catheter. One has a vent hole and the other does not. When the vented rigid catheter is inserted, no suction is being performed because of the vent hole. Once the desired depth and location are reached, cover the vent hole with a thumb or finger and begin suctioning. Remember, side to side, only on the way out, and only for 15 seconds. The procedure for the unvented rigid catheter is slightly different. To prevent suctioning on the way in, crimp the suction hose, release it, and begin suctioning once the proper depth and location are reached. The softer French catheter is used for suctioning through the mask of an EOA or through an endotracheal tube or through a stoma or nasal passage. When measuring for suctioning through the EOA mask or ET tube, measure from the tip of the earlobe to the top of the mask or top of ET tube respectively. For stomas, never insert more than a couple of inches. If the catheter becomes clogged with secretions, dip it into a container of sterile water or saline and allow the suction to rinse it out. Other types of non-electric portable suction devices are available commercially or can be made with simple medical materials. Whatever type of portable suction you have, it must be brought in to all calls. Any patient has the potential to require suction, and it is unprofessional not to have suction readily available when needed. Airway Adjunct Overview. When a patient is unconscious, the airway may become obstructed by the tongue. In fact, the most common cause of airway obstruction in the unconscious adult is the tongue. In addition to manually opening the airway, it is important to ensure a patent airway by using an airway device such as an oral or nasal airway. When a patient is alert or responds to verbal stimuli, there is no need for an airway device. However, if a patient is responsive only to pain or is completely unresponsive, an airway device should be attempted. After opening the airway manually, attempt to insert an oral airway. Absence of a gag reflex doesn't necessarily mean the patient requires airway management. Approximately 1/3 of people have little or no gag reflex. If the patient gags on the airway, abandon the attempt. Inserting an oral airway into a patient with an intact gag reflex could result in vomiting and aspiration, or trigger spasms in the airway, resulting in occlusion. If a gag reflex prevents insertion of the oral airway, consider a nasal airway if not contraindicated. Nasal airways are better tolerated in semi-conscious patients. Oral and nasal airways come in various sizes and must be properly sized for each patient. Inserting an improperly sized airway can actually become an obstruction. If the proper size is not available, never use the wrong size. A properly sized airway inserted incorrectly can actually push the tongue over the airway, creating a partial or complete obstruction. Oral and nasal airways do not ensure a patent airway. Often, manual maneuvers such as head tilt chin lift or the modified jaw thrust must be maintained. Finally, since airway insertion can stimulate vomiting, suction should be available. Oral airway. Oropharyngeal airway, also known as the oral airway or OPA, is a curved piece of hard plastic or rubber that, when inserted correctly, helps keep the airway open by holding the posterior tongue away from the top of the airway and providing air passage either through a tubular center or via channels along the side. The device also allows for oral suctioning and prevents the jaw from clamping shut as during a seizure. OPAs are disposable and come in a variety of adult, child, and infant sizes. Some brands of airways are color-coded for easy identification. Sizing an oral airway is just like sizing a suction catheter. Measure from the corner of the mouth to the tip of the earlobe. If the patient's mouth is not open sufficiently, open it with the cross-finger technique. There are 3 ways to insert an oral airway. The first way is to insert the airway upside down, avoiding the tongue. If the airway is inserted in the direction it will remain, it can actually push the tongue down, allowing it to obstruct the airway. Therefore, insert it upside down along the roof of the mouth until it reaches the soft palate, about halfway down. Then rotate it into place. The flange should rest on the front teeth. Use caution, as this method can cause trauma to the palate, especially in children. An alternate method is to insert the oral airway sideways and rotate it 90 degrees into place once the distal end is past the anterior tongue. The third method of insertion is to open the mouth and secure the tongue with a bite stick or tongue depressor, while inserting the OPA in the direction it will be used. Holding the tongue in place prevents it from being pushed down during insertion. No matter which way the OPA is inserted, it does not need to be rotated to remove it. If removal is necessary, simply pull it straight out. Nasal airway. Patients who need an airway device but cannot tolerate an OPA because they are semi-conscious or still have a slight gag reflex should receive a nasal airway if not contraindicated. The nasopharyngeal airway, or NPA, is contraindicated in any patient with known or suspected trauma to the face or head. These patients could possibly have a fracture of the cribriform plate behind the nasal cavity, which might permit the NPA to be pushed into the brain rather than down the airway. To size the NPA, measure from the edge of the nair to the tip of the earlobe. Often, the right nostril is larger than the left, so the first attempt to pass the NPA should be in the patient's right nostril. For that reason, all nasal airways are designed with a bevel on the left side. Before insertion, lubricate the NPA with a water-soluble jelly. When inserting the NPA, make sure the beveled side is toward the nasal septum. Otherwise, the sensitive tissues in the anterior nose might be injured, causing a nosebleed. Rotate the NPA back and forth as needed to advance it. Keep in mind that the opening into the nasopharynx is in the posterior direction. The most common mistake when inserting the nasal airway is attempting to insert it up the nose without making a posterior shift. Insert the NPA up the nose first, then change the angle of insertion to posterior to enter the nasopharynx. If for any reason insertion into the right nostril is difficult, attempt to insert the NPA into the left. In order to insert the nasal airway into the left nostril and keep the bevel toward the septum, insert it initially upside down until it passes into the nasal cavity. Then rotate it into its proper position. It is not uncommon or inappropriate to use two nasal airways simultaneously. Artificial ventilation. Some patients require ventilatory assistance because of inadequate respiratory rate and/or volume of respirations. There are several devices that can be used to artificially ventilate patients. Regardless of which device is used, there are some basic rules for effective ventilation. Artificial ventilation exposes rescuers to potential infectious contamination. Therefore, personnel should exercise proper precautions, including gloves, goggles, and possibly a gown. Effective ventilation also requires strict attention to maintaining an open airway. Please see our other videos on opening the airway in trauma and non-trauma patients, as well as our videos on use of airway adjuncts. Ideally, the patient should be supine during ventilation, although this may not be possible initially in rescue situations. When a patient requires ventilatory assistance, it is imperative to be mindful of the need to lessen gastric insufflation as much as possible. This is accomplished by using good technique and all available airway devices while ventilating the patient. However, no matter how good the technique, some air always enters the stomach. How much air enters the stomach with each breath depends partly on the patient's anatomy and partly on the ventilator's technique. If the stomach becomes too full of air, the risk of regurgitation and aspiration increases greatly. Also, gastric distension inhibits good ventilation because the air-filled stomach presses up against the diaphragm. To reduce the incidence of gastric distension, the ventilator should use as many of the following techniques as possible. Position themselves comfortably. Open the patient's airway manually, preferably in the sniffing position. Use an airway device such as an OPA or NPA. Administer breaths slowly, ideally over 1 second. Stop inflation once chest rise is visible. The application of cricoid pressure or Sellick's maneuver is no longer recommended according to the 2010 American Heart Association guidelines. The last thing about artificial ventilation before getting into the technique is the rate of ventilation. One of the most common mistakes in artificial ventilation is ventilating too fast. In an unwitnessed arrest, it is acceptable to give the patient a few breaths in succession to help clear out carbon dioxide. However, if too many breaths per minute are delivered, the patient will have a pH shift in the other direction and become alkalotic. Therefore, careful attention must be paid to the rate of artificial respirations. At the current time, the accepted rate of ventilations for adult patients is approximately 10 to 12 per minute, or 1 breath every 5 to 6 seconds. In cardiac arrest situations, 2 ventilations are given after each set of 30 compressions. Check current American Health Association standards on adult, child, and infant ventilation rates, as standards can change over time. One ventilation device is the bag valve mask, or BVM. The BVM consists of a squeezable bag, a ventilation mask, and a one-way valve with a 15mm adapter for connecting to the mask. BVMs should also have oxygen supply capability and a reservoir. BVMs come in 3 standard sizes: adult, child, and infant. The ventilation masks also come in a variety of sizes and styles. Typically, infant BVMs have a pop-off valve that releases air when the pressure exerted exceeds 40 centimeters of water. This is to prevent unintentional overpressurization, which could cause a pneumothorax. The pop-off valve can be overridden if extra pressure is desired, such as in the case of foreign body airway obstruction. Without oxygen attached, the BVM will deliver room air, which contains 21% oxygen. When high-flow oxygen is used, the concentration of oxygen becomes 50 to 80%. With high-flow oxygen and reservoir, the oxygen concentration reaches 100%. High-flow oxygen should be attached as soon as possible. But when a patient is not breathing adequately, it is important to ventilate as soon as possible. Do not delay ventilations to attach oxygen. The adult BVM holds 1,800 milliliters of air, and approximately 600 milliliters of it is expelled when compressed with one hand. Whenever possible, it is preferable for 2 people to use the BVM. One person uses 2 hands on the mask, while the second person squeezes the bag. To ventilate a patient with a BVM, open the airway manually and insert an airway device. Next, use 2 hands to apply the BVM mask. Place the narrow part of the mask on the bridge of the nose and stretch the mask while seating it on the face. The lower part of the mask should sit between the lower lip and chin. Seating the mask after stretching it uses its natural tendency to return to its shape to improve its seal to the face. If the mask is allowed to unseal, it should be resealed in the same manner. Use the EC clamp method to maintain a tight mask seal. To do this, place your thumb and index finger around the chimney of the mask and push down. Place your other fingers under the chin and lift up. Be careful not to press your fingers into the soft tissue under the mandible, as that can cause obstruction. Also, use care not to press your thumbs into the patient's eyes when ventilating. The EC clamp method maintains a tight mask seal, while at the same time maintaining head tilt. When 2 rescuers are available to ventilate with the BVM, the rescuer controlling the mask should use both hands to maintain a tight mask seal and maintain an open airway. In this case, the thumb should be used to keep the mask seated to the face, while the fingers are used to lift the jaw. If no C-spine injury is suspected, the patient's head should also be tilted back and lifted into the sniffing position. Grab the BVM by the valve. This allows for greater control while attaching it to the mask. Secure the BVM to the mask and begin ventilating. Squeeze the bag slowly, watching for chest rise. Ventilate at the proper rate. As soon as possible, connect the BVM to high-flow oxygen and make sure a reservoir is in place. The second ventilatory device is the pocket mask. Ventilating by this method is called mouth-to-mask. The pocket mask has a disposable one-way valve that allows the rescuer to ventilate by mouth. The advantage of this is that the ventilator can feel the patient's lung compliance while exhaling into the mask. Mouth-to-mask also allows for greater ventilation volumes than usually achievable by single-person BVM technique. The primary advantage of the pocket mask is that it allows a single user to ventilate a patient while using the modified jaw thrust. It is nearly impossible to ventilate these patients with a BVM unless using the two-person technique. The technique for applying the mask is the same as for the BVM. And like the BVM technique, use all possible techniques to improve airway opening and minimize gastric distension, such as manual airway opening, use of airway adjuncts, slow ventilations only until chest rise is observed. One other note about the pocket mask is that its adapter fits inside the adapter of the BVM, so it can be used as a BVM mask if necessary. The third ventilation device is the flow-restricted oxygen-powered ventilation device, more commonly known as the demand valve. It delivers 100% oxygen directly from an oxygen tank. It is called the demand valve because it can be activated by a trigger or button on the device. The biggest advantage of this device is that, like the pocket mask, a single user can operate it. In 2018, it was removed from the national EMS scope of practice and has been eliminated from practice in some places, such as Rhode Island.